Welcome all of you who have joined to our webinar today on what you need to know about COVID-19, the coronavirus, and some particular angles that our panelist, Dr. William Haseltine, will share. This is a collaborative effort by Tech Care for All and our Medical Learning Hub in partnership with Access Health International, and I am Pam Bolton, Senior VP for Global Health with Tech Care for All. I will turn to Dr. Haseltine in a minute, but first I want to let you know that we will reserve some time toward the end of our brief time, half hour, for your questions. Please submit them at any time via the Q&A box, and we will read them out in order to be able to answer them as you are all on mute during the program. We have some listeners from India, from East Africa, from the US and around the globe, so I'm excited to see a good mix, and I thank you all for making the time. Dr. Haseltine, you are a biologist by training, a virologist and medical researcher, long-standing Harvard professor who set up 2 departments there, also a highly successful biotech entrepreneur and founder of no less than 12 companies. I know in your recent iterations, you are also a prolific author and advisor to hospitals and health systems, and even an anthropologist. So I don't think you sleep very much, but we have heard from President Trump just last night that the US is suspending flights from Europe, I guess without consulting European leaders. So clearly this is growing into a very big threat, and now declared a pandemic by WHO yesterday. And I know that you are called on by health systems and countries to provide your advice. So why don't we start, if you can just share your thoughts about what is most important right now to contain this virus's spread. And perhaps you could speak to needs of highly affected, somewhat affected and minimally affected countries, since we have all of those represented on the call.
Thank you, and thank you for arranging the webinar today. And it's a pleasure to be working with Tech Care for All. I would say that the most important thing in any epidemic, including this one, is clear, consistent, and credible communication by our political leaders. We have governments for a very good reason. Our governments are intended to protect us. We give up some of our hard-earned money and some of our freedoms in return for the expectation we'll be protected from wars and from pestilence and from other calamities. We want our leaders to be clear, consistent, and credible. In addition to that, we want our governments, both state, federal, national, state, and local, to be doing whatever they can to contain the epidemic. There are some governments, now that is independent of whether it's currently a major epidemic or whether it is just an emerging epidemic. The reason it's called a pandemic is probably every country in the world has at least some cases today. There may be 1 or 2 remote Pacific islands that don't, but basically every country has some infection, and it can spread very quickly. We know something we didn't know a little while ago, that it can spread just by breathing. You don't have to touch anything. That's a relatively new fact. So this is a cold virus with a very bad habit that it's more lethal than others. It will kill people, and it's transmitted just like we know colds are transmitted. And therefore, we need governments to protect us. Now, what can a government do? A government can identify people who are infected, can contact trace, and can, at this point, quarantine those people who are likely to be infected. But in order to do that, you need testing. You need widespread testing, wide-scale testing. Very few countries have that. The one thing I would urge all governments to do is make testing free and as widely available as possible, and administered through the public health system, not through private clinics. So we in the United States are making one mistake after another. Let's hope other countries don't do what we've done.
Thank you. Testing clearly will be very important. I know also that China was very successful in halting further spread, and according to the Fred Hutch Cancer Center, researchers there averted many millions of cases through what we now call social distancing and non-pharmaceutical measures, basically keeping people at home. And I happen to be right near a hotspot in New Rochelle. What do you advise the US localities to do, and the same for other highly affected countries in the way of social isolation?
I don't know if we or other countries are capable of conducting ourselves as China has done. But we can do a lot more. We know through years and years of public health measures how to do contact tracing, how to test people, and how to request or then, if necessary, force people into quarantine. That is something we must do, and we are not doing it. We don't have effective contact tracing, and we certainly don't have effective tracing. That's for the US. And if there's any other country that is listening in, that's what we have to do. Very straightforward, very simple. It's sort of simple blocking and tackling. We know that can be effective. We've seen the effects of that in other epidemics, and we have seen the effects in China. So we can do that. I don't know if we have to go to the extent China has, but we can certainly do a lot more than we are. But key to that is testing through the public health system, testing, identification, and quarantine. And if people break their quarantine, they should be subject to penalty, which means forcibly quarantined. That is, all countries around the world have on the books the ancient Roman dictum, public health is the greatest good. That means it trumps every other law. Public health safety trumps every other law.
Very interesting, given that in Seattle, apparently there were samples that could have been tested for coronavirus for over a month, and the researchers there were unable to secure federal approval to do so. Finally did. But this is a real lesson. Now, speaking of lessons, you were involved as one of the scientists, and sometimes in a controversial position related to the HIV virus in the early part of the epidemic. Are there lessons that you see still from that epidemic or pandemic that are applicable? I know the viruses are very different, but I imagine there may be some parallels, or perhaps you'd want to speak to SARS or MERS or other more recent epidemics.
There are, excuse me a second. There are very clear parallels. First of all, when there's a new epidemic, the first reaction of most people is denial. The second reaction is it's their problem, not my problem. And finally, it's panic. That is pretty much the scenario that happens every epidemic. And it certainly happened with HIV, and it certainly happened with this one. But there are things to learn from very clear lessons. One of the things that I warned in a speech to Congress, and many other people have warned, not only over HIV, but over SARS, over MERS, over Zika, over Ebola, is preparedness is everything. You have to be prepared. And we are prepared at this point for bioterror attacks. We've passed legislation. We have special FDA rules that allow rapid approval of drugs. We stockpile drugs and vaccines just in the case we are affected by a bioterrorism. Let me point out, there's a much worse terrorist out there than any other human being, and that's nature. Nature is working overtime to try to crack our immunity, to try to find chinks in our healthcare armor, to attack us. There's nothing new, we know that. Flu does it successfully every year. Antibiotic resistance is on the rise. Malaria keeps changing. There's antibiotic resistance, tuberculosis. Coronaviruses, as we've seen, they're now learning how to do this. Think of nature as this enormous artificial intelligence that's trying every combination it can to get us. Well, we know that's true. We're living in the natural world. It's like living on a volcano or on an earthquake fault. You have to be prepared. If you're living on an earthquake fault, you build earthquake resistant buildings. And if you don't, you die. That's what happens. And we see that all over the world. We aren't prepared. And no matter how many times these infections come to get us, we don't learn the lesson that we've got to be prepared. For example, when SARS and then MERS came, the universities and biotech companies all over the world created a whole series of drugs that stopped 3 of the proteins in the coronaviruses. They stopped the helicase, the polymerase, and the protease. You can go online and look at all those compounds. What happened to them? Why aren't they approved? Because there was no pharmaceutical economic model that people thought was worth their money to invest to bring those to FDA approval. Well, that's a perfect example for what should happen with a government. A government should bring those to approval and should stockpile them. We knew that. You know, a case in point is my daughter did a sculpture. She won a contest in Singapore to do a sculpture of the SARS protease. Sitting in the middle of that sculpture on the pavement is a model of a drug that stops the SARS protease. And you walk through it, and symbolically, you stop SARS. What happened to that drug? The sculpture is there. The drug isn't there. Why? Because nobody thought there's going to be another coronavirus. What about with MERS? If you go back and you read the literature, which I've done recently, there are scientists saying, please develop these drugs. There's going to be another coronavirus epidemic. We should have had them. Now, can we learn? If we don't have them today, let's hope we have them tomorrow. One way this epidemic could end sooner than people are thinking about is another lesson from AIDS. We don't have a vaccine for AIDS, yet we've controlled it. Controlled it through public health messaging, first of all, through development of a lot, over 30 antiviral drugs that work in combination. They work to prevent infection in pre-exposure prophylaxis, and they prevent people from dying who are infected. We can develop those drugs. I can tell you as a drug developer who's developed these kinds of drugs before, protease inhibitors, drugs to stop anthrax and prevent anthrax infection, the chemoprophylaxis and chemo treatment, chemical treatment, especially with combinations of drugs, works. So that is something that could happen sooner than vaccines. All those drugs exist. Let's bring them over the line, get them FDA approved, and we have the authorities to do that. We in this country should do it, and all other affected countries should do it too.
Yeah, certainly that is true that with the AIDS epidemic, it was drug treatment more than any of the prevention message and behavioral work that was done previously that slowed the spread, right? Because once people are on ARVs, then they are no longer infectious.
They have a new motto, which is undetectable, means you're effectively treated with antiviral drugs. Untransmissible, U equals U. That would be the same for coronavirus. U equals U, undetectable, untransmissible. Treat the people, and I would say contact trace and prophylactically treat all those who are theoretically exposed. That's what we need to do, and we should have had those drugs in stockpile. Let's hope we learn the lesson and stockpile them for the next, because there will be another lethal coronavirus infection. And by the way, we should do the same thing for flu. Why don't we have drugs for flu? Same reason. Pharmaceutical companies don't think it's economically viable. Well, that's where the government should step in. The next thing that could get us is a nasty flu. It could kill 1 billion people. That's not fanciful. Last time, when there were far fewer people and much less transportation around the world, it killed 50 to 100 million people. It could do the same, and we don't have the drugs that we should to protect it. We're not going to be able to make a vaccine in time if it pops up, and it could pop up at any minute. Actually, all of us in virology have been wondering where it is. It should be here. It's late.
I mean, it seems like a perfect argument for the sorts of public-private partnerships that the Gates Foundation and the financing mechanisms like Gavi have pursued. If you can de-risk
Yeah.
this and enlist
It's
participation.
not for the private
Uh,
sector. It's for the government.
okay.
The government should do it. The Indian government should do it. The Russian government should do it. The French government should do it. The British government should do it. Our government should do it. It's a governmental responsibility. That's why I began. Pandemics are not the private sector's major responsibility. We have government to protect us. Why aren't they doing their job? That's what their job is. We pay our valuable hard-earned tax dollars. We give up some of our freedoms. We want protection in return.
We have some callers from countries in Africa and from South Asia. These sound like advocacy messages that are very applicable globally. Would you suggest, how would you suggest that people working in public health or policy or even health providers in those countries proceed to enlist their government's proactive support?
I think it's very important to be, if you're in the health sector, to be an advocate for the government to step up and do its job. All governments have a public health ministry. All governments have the authorities to contact trace and to test. Every country should be an advocate for very widespread available testing for free. They should participate in contact tracing and quarantine for those infected. And if the country has the resources, they should urge them to do the research and to stockpile drugs for flu, for coronaviruses, and other impending epidemics. You can't hear you.
That's very good advice. In a couple of minutes, we will turn to some questions from listeners, but I have two more for you. So the first is, I know that you've pointed out that in Korea, for example, they've set up some very inventive ways to improve testing with parking lots filled with drive-through testing facilities that people can very easily access. And I've even seen companies promoting test-at-home kits, which sounds a little sketchy to me. What's your take on these kinds of interventions? Are they useful? Should countries do them?
Let me say, first of all, about South Korea. Surprisingly, South Korea ran a coronavirus preparedness exercise in early December before they knew coronavirus was coming. Everybody in public health knows another coronavirus was coming. At least Korea did something, so they were perfectly prepared. Why weren't we? Why wasn't China? Why wasn't Singapore? Why wasn't Japan? We know they're coming, and they're going to come again. We need to create the structures, not wipe out our structures in our federal government, which our president did. We need to strengthen those and run exercises. When we thought it was bioterrorism, we were prepared. What makes people think nature's not the terrorist when we know it is? That's the first thing I would say. So you can do better. And you had a second part of your question?
Yeah, no, I have one last question. Now, Tech Care for All, our company, which is a social impact company explicitly dedicated to improving healthcare coverage and quality, is working on digital health technologies. And we've seen, I think Zoom stock has gone up quite a bit, and people are moving college courses to online and live stream formats. Medical consultation should probably be taking place more via telemedicine. I just would like to see if you have thoughts on how digital health can be leveraged to help improve not only our response to prevent, but also to manage this ongoing threat.
I think this epidemic is going to be a big boost for telehealth. I can tell you my own health network, New York University Langone, NYU Langone, has issued through a variety of communications, don't come in, contact us through telehealth, and then we'll ask you to come in if you need to. And I'm sure it's not the only one. It's happening across the country. Fortunately, they put in place last year an effective telehealth system. Everybody who doesn't have it should be rushing to do it because that's what you want to do. And eventually, you'll have a little monitor you'll plug into your computer. You'll take your temperature, your blood pressure, and it'll get much more sophisticated. You know, I can imagine a time when you'll get all your biochemistry, your breathalyzer, your, you know, prick a little bit of blood, and it's all that, it's going to flow right through your computer to your doctor. And it's going to save a lot of money, a lot of time, and keep us a lot healthier. And there'll be on-time real monitors for people with active long-term chronic diseases. That information can flow directly to the healthcare provider. I say there's another important integration that we need to do, and that is we need to integrate social care with healthcare. Who knows you better than the social worker? And one of the most important things to know about patients is their social determinants of health. Are they eating properly? Do they live in clean housing? Who are they? Who are their friends? Are they socially isolated? All of these questions are really important. And in an epidemic like this, where old people are at higher risk, it's the social workers who are going to be interacting with them. We should integrate patient and social care records, and we should integrate the administration of social care and healthcare. That's the next big step. And information technology can make that work extremely well. There's a few experiments. Great Britain is trying that right now. And they, I think, probably have the best system to control this epidemic because they are pushing healthcare out into the community and into homes. That's where it should be, not in hospitals. Hospitals concentrate disease.
Absolutely.
I have friends whose parents and uncles and aunts in Wuhan got infected by standing in line waiting to see doctors in their massive 5,000 bed hospital complexes. Okay, that isn't what you want.
Yes, that's right.
Right? You don't want hospital-centric care in epidemics like this. You want distributed care and telehealth and telemedicine as much as you can.
Well, that's certainly a very good argument for the movement, which is very strong now, as I know you know, toward community health workers in communities of the global south and lower resource settings.
But it shouldn't be right. It shouldn't be there. It should be here too.
It should be here as well. Yes, but
not as well. It's got to be here too because look, the health, the demography, which is all of these older people, including myself, needing all sorts of different kind of health support. You can't do it in a hospital-centric system. It's inconvenient and it's dangerous. You want to do it in outpatient, community care, and at home. And that's the revolution we need here. And in poor countries, they need it just to give high quality health to most of their people. It's the same, I see it as a unified program of integrated health where you integrate all aspects of healthcare services, especially home and community and village care, with social care as well.
Absolutely. So I want to turn now to see if we, I think we have a question from our India Tech Care for All CEO, Dr. Sachin Malhotra. And Sachin, are you able to ask your question?
Absolutely, Pam. Can you hear me okay?
Yes.
Thank you, Dr. Haseltine. This was a wonderful talk. It was delightful here. So my question, and I have a couple of them. So I'll start by a simple one, which comes out of what you talked about, epidemics and pandemics that you may have experienced in your lifetime. And do you think nations are learning from these experiences? And if so, what are the sort of differences we are doing with COVID-19 today that you may have seen as different compared to what other epidemics you've seen before?
Well, learning from experience is, especially at a social level, is a complex phenomenon. And as we've seen, some people have learned lessons better than others. I think the Chinese, Hong Kong, Singapore, South Korea learned a lot from SARS and MERS. Other countries, not so much. Have we really learned the lessons from flu? No. Are we really learning the lessons of antibiotic-resistant organisms? No. No country is. Are we learning the lessons from multi-drug resistant tuberculosis? No. Are we really preparing for a wave of tropical diseases, dengue, chikungunya, yellow fever, Zika that are moving into temperate zones because of climate change? No. So learning from past experience is very spotty. It can be done, as you've seen by the very powerful response that China, Singapore, Hong Kong, and South Korea have gone through, but most other countries haven't learned those lessons. And none of the countries learned the lesson to prepare by getting the drugs stockpiled to prepare for the next one. I guarantee you, sometime, maybe my lifetime, maybe not, there is going to be a terrible flu epidemic, and we are not going to be prepared unless we right now develop the drugs and stockpile those drugs that can prevent transmission and can cure the ill. It's going to happen. And I'm not the only one who says that. Everybody who thinks about it, who's a virologist, epidemiologist, knows it will happen, whether they're in China, India, Africa, South America, or the United States, and let's not forget Australia. It's something we know, but we're not learning.
Yeah, drug stockpile. That's, I think, well, it makes me want to ask about whether these drugs would be able to cope with a wide range of, unexpected outbreaks. But I want to give a chance to our East Africa CEO, Dr. Benson Chuma. Benson, are you there and able to ask a question?
Yes, I am. You can hear me?
Yes.
Oh, great. And thank you for this insightful talk. So my question is, well, we've seen in the last few days, the disease has spread to Africa. We have about 10 or so countries. I think actually 2 days ago, that was 11 countries in Africa that have reported cases. But ironically, the numbers are still very low relatively compared to other parts of the globe. And from what has been reported, most of these cases, the index.
You get to your question, we don't have much time.
Sorry?
What's your question? We don't have much time.
Yeah, so these appear to be travelers mostly from Europe. Do you think there are lessons to be learned from this? And do you think it's just a matter of time? And would you guess or know what will be driving this pattern?
The first thing to say is you don't know how many people are infected in Africa because you don't test. So how would you know? You have no idea. Same in India. You have no idea. It could be 100,000, it could be 1 million, and you wouldn't know it. That's the first thing to say. So without testing, you don't know. So you've got a few very isolated cases, you surely have many more. And if you don't have many more now, because of the exponential growth of this infection, you're going to have many more too. So that's the first thing to say. And your second question was what to do about it? Just what we've been talking about for the last half an hour. Maybe we have time for one more question.
Yes, well, maybe if we don't have one from the field, I would actually like to ask the question that I implied just a minute ago. So if we are to stockpile drugs, are you confident that the types of drugs we could prepare in advance would be sufficiently effective to contend with an unknown mutation and new type of corona or other virus?
The difference between vaccines and antiviral drugs is profound in terms of the breadth of their activity. We know that with HIV and AIDS, for example. The outside of the virus is built to change to avoid our immune system. But the inside of the virus, those enzymes that are necessary to replicate, in the case of the coronavirus, the polymerase, the helicase, the protease, are highly conserved. And we already know, by the way, that these drugs that have been tested, the drug candidates, work on a broad spectrum. They work on SARS, they work on MERS, and they work on other coronaviruses because they've already been tested on those. So same thing with flu. Flu changes on the outside, and it rarely changes, and even it does, those have to be relatively conserved. So it's a very different kind of approach. It doesn't mean the viruses can't get resistance if you put a long selective pressure. They can. That's why we have to talk about combinations of drugs. Same for even hepatitis B. Hepatitis C, you can cure hepatitis C with protease inhibitors, but right now we've learned you better use 2 different ones. not just one. So the real treatments, Egypt just eliminated the disease. I have a paper coming out in the New England Journal which describes it. They've treated more than 4 million people in Egypt and eliminated hepatitis C with combination drug therapy. That's what you can do with drugs. We forget, everybody's focused on vaccines, but that isn't the only tool we have. I think this is probably the end, but I want to thank you very much for the opportunity. I hope it's been useful for you and your team.
Thank you very much indeed, Dr. Haseltine. This was amazingly useful. I think you underscored about some very key themes. Be prepared, expect the next one. Government must lead. You, undetected, untransmissible, and test and contain. So I very much thank you for your time. And we will make this available afterwards as a recorded lecture so that people can continue to benefit from what you've told us today.
Thank you, Pam. It's been a pleasure.
Very good. Thank you all. And with that, we will end the session.